So it's a good question. I think there are a couple of things that help determine your choices. One is efficacy. So alectinib is better than crizotinib, so we wouldn't think about using crizotinib first. Ceritinib has never been compared to crizotinib, but it was compared to chemotherapy and found to be better. Not a surprise, because when you compare a targeted agent to chemotherapy in a targeted subgroup, those patients always do better with the target. But the progression-free survival with ceritinib was not as good as what it was in the ALEX trial, with all those caveats of cross-trial comparisons. But what we also saw with the ceritinib data is that ceritinib is more toxic than alectinib. So your first-line option really then defers to alectinib. I think an important thing that's going to emerge with time is the mechanism of resistance to these agents. We know that they have different mechanisms of resistance. The one we worry about the most is G1202R, because none of the drugs that are currently approved target G1202R. Brigatinib has a little bit of activity, but we know lorlatinib does have activity, and we don't really know insertinib in terms of activity against G1202R. So it may be that a patient starts on one ALK inhibitor, develops resistance, at that time gets a biopsy, and we figure out which drug to go to next. It's going to be very hard to say which drug is better if the PFS with brigatinib from the ULTA trial and insertinib from the EXALT trial are all identical. I think that what will happen is comfort in physicians in using the drugs, but I also think toxicity will help us determine which drugs to use first, and then overall survival is going to be the key. Progression-free survival is nice for a pharmaceutical company, but overall survival is what patients and physicians care about.